SRS constraints. The brainstem should have a max of less than 12. The optic chiasm should have a max of less than 8. In the new RTOG studies, they use 10 gray for the actual chiasm, describing the risk of RION as less than 1% with a D max of the optic apparatus less than 10 gray. The optic nerves themselves should get less than 8 gray. The cochlea should be a mean of 6 gray and a max less than 12 gray. The brain V12 gray should be less than 10 cc's if you're treating with 1 fraction, and V18 gray less than 30 cc's in 3 fractions per minute. The dose fall-off is approximately 10% per millimeter. Review TG 101 of planning to say any CNS spine doses in 3 or 5 fractions. External beam planning constrains the brainstem max of less than 54, point dose to 60. Chiasm, max less than 56. Nerves, max less than 55. The risk of optic neuropathy, rates of less than 3% for 55 gray, 3 to 7% for 55 to 60 gray, and 7 to 20% for greater than 60 gray. Cochlea, mean less than 45 gray is associated with less than 30% risk of sensory neural hearing loss at 4 kilohertz. Retina, less than 45 gray. Lens, less than 7 gray. Spinal cord, less than 45 gray. Hippocampi, max of 12 gray. Mean, less than 9 to hippocampus itself. No margin needed. Contour on T1. SRS spine fractionation options include 6 to 7 gray times 5, 8 gray times 3, 16 to 18 gray times 1. Ocular melanoma, I'll briefly go through this. No BRAF mutations, liver mets are common. Small melanomas can be watched for growth prior to treatment. If there's growth, then the patient knows the melanoma will eventually destroy vision and increase the chance that cancer cells will spread. The COMS, Collaborative Ocular Melanoma Study, was interested in how many small melanomas would grow and over what period of time. It found that more than 25% were found to grow within 2 years of follow-up. Since choroidal melanoma growth is the best predictor of vision loss and increased risk of METs, COMS underscores the need to follow patients. Proton for the treatment of uveal melanoma is more expensive than brachy. Plaque brachy provides a mobile radiation field that moves with the eye. Proton is static. On a meta-analysis, there was no difference in the risk of enucleation between charged particle treatment and brachy. Proton allows for treatment of larger tumors, including those touching the optic disc. COMS looked at brachy versus enucleation